loud. Cool. Nice to, I mean, I knew what you looked like because I follow you on Twitter and whatnot, but movement, that's different. So that's cool. And then we're going to meet in person next week in Boston.
Absolutely, in Boston. I'm so excited.
How fun. And you're in Rochester?
In Rochester.
Is it cold yet?
It is beautiful right now. 65 degrees.
Perfect.
Wonderful.
Lovely. Let's give people a few more minutes to join. Welcome, welcome. We'll get started in just a moment. Hot topic today, so I think people are excited.
Yeah, winters really get rolling here in November, and it gets cold here.
I have heard about Minnesota winters. You know what's so funny, John? I think probably about 5 people from Minnesota in the last year alone have asked me if I'm from Minnesota, because apparently I have a little bit of a Minnesota accent, which is bizarre because I've never even been there.
Very interesting. Do you say A? That's the big thing.
I don't know what I say to make people think that, but it's so interesting. I've been asked several times by different people if I'm from Minnesota, and I'm like, no.
Oh, it's a great place to live. I think it's a nice state. The summers are gorgeous. The winters get a little bit long.
Oh, I'm sure. I can only imagine. It's definitely colder than Boston, and Boston is cold in the winter.
Yeah, Boston's really nice. Yeah, we had a visit in Boston over spring break. Had a really good time.
Oh, fabulous. Good. Okay, I think we have a nice group of people to start with. So let's get the show on the road. Hello, everyone. My name is Samira. I am the founder and executive director of the Samira Foundation. We are a nonprofit global organization dedicated to raising awareness of NMOSD and MOGAD, building communities of support for patients and their caregivers, funding research and patient advocacy. Today, I am so excited to introduce you all to Dr. Chen, who is a neuro-ophthalmologist at Mayo Clinic in Rochester, Minnesota. Today, he will be discussing and answering live questions about treatment options for MOGAD patients. So clearly this is a hot topic and we've brought in the right expert to talk about it. So very excited to dive in. But before we do so, we do have a few housekeeping items. So the first is that this is a recorded session. So the webinar will be available for replay and for you to reference on TSF's YouTube and Facebook video libraries. So make sure to subscribe so that you don't miss anything. Second, a big shout out to Horizon Therapeutics. This programming is made possible through a patient education grant that we received from Horizon. So thank you for your ongoing support. And lastly, towards the end of the webinar and our time together, we will have a dedicated section for live Q&A. So please don't feel shy. Dr. Chen is here to answer all of your questions related to treatment options for MOGAD. You can populate them either in the chat function or the Q&A function, and we'll get to as many as possible. So without further ado, Dr. Chen, thanks for being here. I hand it over to you.
Great. Well, I am very, very excited to be here. As Samira said, I am a neuro-ophthalmologist at the Mayo Clinic, and I've been here since 2014. And, you know, I have a very special interest in MOGAD and NMO. And the Mayo Clinic has a long history of trying to better understand these diseases. It was actually the Mayo Clinic with Venin, Dr. Venin, in 2004 was actually the first person to identify the biomarker of aquaporin-4 antibodies, which is the biomarker for NMO spectrum disorder. And then more recently, there was the identification of MOG antibodies for MOG antibody-associated disease, or MOGAD, initially discovered in Europe. But at the Mayo Clinic, we pioneered the first essentially biomarker or assay in the United States So the Mayo Clinic was the first to offer that, and that was started in 2017. So really, we haven't had that biomarker available in the United States that long. We've got a better understanding and recognition of the disease now, and we've got a better understanding of the treatment. I work very closely with Dr. Flanagan and Dr. Pittock, who are neuroimmunologists at the Mayo Clinic, and we have lab meetings every week. We chat about interesting patients and talk about, kind of the next thing we want to try and understand better about disease. Again, what I'd like to do is talk about treatment options for MOGAD. Samara, it looks like it says that I can't share my screen right now.
Hold on a second. I am going to make you a co-host.
But again, the understanding of our diseases for MOGAD is certainly growing a lot. We've, again, had this biomarker available commercially available just since the end of 2017. So, we're getting a better and better understanding over time. But I just thought I'd kind of go through some slides and talk about how we approach patients with MOGAD. I thought I'd start off with just a classic case of MOGAD optic neuritis. This is a 48-year-old male who presented with blurred vision and pain in both eyes. He said the vision was very, very blurry. He had a lot of pain when he moved his eyes around. And for him, the pain actually even started before the vision loss, which is pretty typical for MOGAD. And the vision loss was pretty severe. Over past about 2 or 3 days, the vision started at 20/20 normal, and it dropped all the way where he could only count fingers. That's how debilitating the vision loss was. And then when we got an MRI, we saw profound enhancement or inflammation of the optic nerves. You can see in both eyes, there's this inflammation there. Normally the optic nerve is kind of gray, but you can see all this white is inflammation. And it's spilled beyond the optic nerve into the optic nerve sheath and fat. So really this profound inflammation, that's a pretty classic symptom for MOGAD optic neuritis. So anytime we have a patient with optic neuritis, especially severe optic neuritis, we tend to treat them with IV steroids. And this patient had almost immediate recovery of vision. So again, he could only count fingers, but after about 2 or 3 days of steroids, he could see 20/20. He was essentially back to normal. So it's actually faster recovery than you typically see with other forms of optic neuritis, like multiple sclerosis, where IV steroids does quicken recovery, but it quickens it from maybe 4 or 5 weeks to 2 to 3 weeks. This patient, again, within 2 or 3 days of steroids, was back to normal, which was wonderful. But when he came off the steroids, he had a relapse. And then every time he relapsed, we treated him with steroids. He got back to 20/20, but every time he came off the steroids, he had relapses. And so he clearly had a steroid responsive, but steroid dependent optic neuritis. And we weren't very surprised to find that his MOG antibodies were pretty high at 1 to 100. So confirmed our suspicions that this is MOGAD optic neuritis. And because he kept having relapses, we ultimately treat him with a medication called azathioprine that led to a stability of his disease. But we'll come back to this case at the end of this talk, and we'll discuss how we approach these patients and how we treat them. I just thought I would start off with just some demographics. This group probably knows about the demographics of the disease, since you probably either have the disease or know someone who has the disease. And it really can affect any age, ranging between 1 to 82, the average age of 30s. But it makes up more than 25% of optic neuritis attacks in children, about 5% of optic neuritis attacks in adults. So certainly a pretty good percentage of patients with optic neuritis could have MOGAD. And unlike NMO and MS, where you have many more females affected than males, with MOGAD, it tends to be closer to a 1-to-1 ratio. And then features of optic neuritis that as clinicians we look for to say, well, maybe this could be optic neuritis, is they get recurrent optic neuritis in about 50% of the time. 50% of the time it's bilateral. And then when we look with our ophthalmoscope and we look at that optic nerve and take pictures, about 80% of the time we'll actually see optic nerve swelling. And that's not something we typically see as often with multiple sclerosis and NMO. So if we see big swollen optic nerves, we think, well, maybe this could be MOGAD. And then about 50% of the time, you'll see on MRI this good amount of inflammation of the optic nerve. But again, it's so much that it spills into the optic nerve, into the fat and the sheath. And this is something we call perineural enhancement. Again, something we don't commonly see with NMO or MS. So again, makes us think about MOGAD. patients with MOGAD optic neuritis present with horrendously bad vision usually 2200 or worse, or oftentimes they can only count fingers. They can't even see the big letter on the screen. So they come in with very scary vision loss, but fortunately they tend to recover very well with steroids, with only about 5 to 10% ending up with a vision of 2200 or worse. And 2200 is that pretty bad vision where you go to an eye chart and you see that big E. If the only thing you can see is that big E, that's 2200, and that's considered legally blind. So occasionally patients with MOGAD can have blindness, but it's much lower percentage in MOGAD compared to NMO, where up to 50% can end up legally blind from an optic neuritis attack. So again, they present with very severe vision loss, just like NMO, but recovery is much better, leading to ultimately better outcomes. And again, they're often very steroid responsive, but sometimes steroid dependent. So again, the most common way that MOGAD disease presents is optic neuritis. And we talked about the ways that, the typical optic neuritis you see with MOGAD. Another common way it presents is transverse myelitis, which is an inflammation of the spinal cord. And there, patients will have symptoms like numbness, tingling, problems with their bladder or bowel are kind of the classic symptoms of transverse myelitis and inflammation of the spine. And if you have a patient with optic neuritis and transverse myelitis both, it actually met the 2015 diagnostic criteria for seronegative NMO. When we came up with these criteria back, 7 years ago, we didn't know about MOGAD. And what we found now is that MOGAD actually explains about a third of patients that are aquaporin 4 negative, because MOGAD can mimic NMO, again, by causing optic neuritis and transverse myelitis. Another thing that MOGAD can do is cause ADEM, which is acute disseminated encephalomyelitis, which is more of a diffuse inflammation in the brain. Again, we don't typically see ADEM in multiple sclerosis or NMO. This is more specific for MOGAD. This tends to occur in children where patients present with headaches, confusion, and it can be pretty severe at times as well. And these are pretty much the three main ways that MOGAD presents: optic neuritis, transverse myelitis, and ADEM. In terms of treatment, as I talked about, they tend to be very steroid responsive. And so we tend to treat them with high dose IV steroids for 3 to 5 days, usually 5 days, followed by an oral prednisone taper over 1 to 3 months. And the reason why we tend to do that longer prednisone taper is they tend to sometimes be steroid dependent. So sometimes if we treat them with IV steroids, they get good recovery. But without that steroid taper, they have a relapse, really soon after that first attack. So that taper of steroids, oral steroids, low dose, tends to try and prevent that from happening. And we have some studies, some retrospective studies suggesting that early steroids may lead to faster recovery and better outcomes. No randomized clinical trial on that, but just kind of looking at our data of 200, 300 patients, it seems like the case. And if you know anyone with optic neuritis from MOGAD, they tend to follow a pretty similar course, usually stressed off with pain with eye movements that lasts 1 to 3 days. Sometimes they'll have a headache behind that eye. Then the vision tends to drop over, anywhere between 1 to 7 days, just kind of keeps dropping and dropping and dropping until it gets to like the bottom, usually where they can only count fingers or something very, very bad, essentially legally blind. And then you treat them with steroids and then they get better. We think that early steroids may help because what happens is, again, the vision tends to drop over 1 to 7 days. But if you catch it where, the vision's only dropped for about 6 hours and they're still sitting at 20/30, 20/40, and you treat them with steroids, you can get them back to normal a lot quicker, a lot faster. And that's why we think early steroids helps. But again, even if you don't treat with steroids, some patients often can recover on their own, even without treatment. But probably early steroids helps. So again, if you've got an acute attack, treat them with early steroids, IV high dose, that oral prednisone taper over time. And if a patient has a severe attack and they don't recover with steroids, we use something called plasma exchange. And I think maybe some of the audience have heard of this. Many of you probably don't need it because usually these attacks respond very well to steroids. But if they don't respond to steroids, then we do something called plasma exchange. So with plasma exchange, what we essentially do is we take your blood and then we filter it through essentially filter out all the pathogenic antibodies, and we discard the plasma that has all the antibodies that are causing problems, like the MOG antibody or the aquaporin 4 antibody if you have NMO. And then we give you replacement plasma that don't have the antibodies. And essentially, we just kind of cycle that bad antibodies out, new plasma in, to essentially get rid of those pathologic antibodies. It's a very, very common treatment for NMO. In fact, most NMO attacks need plasma exchange. For MOG, only about 5 to 10% of attacks need plasma exchange because usually they respond to steroids. But essentially, this is kind of the way we approach acute attacks of MOGAD, essentially high-dose steroids and oral prednisone taper. If they don't recover, which is pretty rare, we'll add on plasma exchange to kind of wash out those bad antibodies. And patients tend to recover within a few weeks, and then we have further recover over 6 to 12 months. And usually 1 year after that first attack, that's going to be your new baseline. You don't expect any further improvement after you kind of get that new baseline. Again, so the bulk recovery happens in the first few weeks, some more recovery over 6 to 12 months, and then at 1 year, you're pretty much where you're going to be. A question I'm often asked is, I'm 6 months in, I'm still kind of down in terms of my vision. Can I get treated with steroids again or plasma exchange again, 6 months in, a year in? And unfortunately, the eye's either going to heal or not heal. Repeat treatments down the road doesn't tend to help very much. And so really, it's kind of treat early, treat hard, and then hope there's recovery over 6 to 12 months. But repeat treatments down the road doesn't tend to help. So that's your acute attack. In terms of chronic treatment, the chronic treatment of MOGAD is actually very different compared to multiple sclerosis and NMO. And that's why it's very important when you have a patient with optic neuritis or any kind of demyelinating attack to have the correct diagnosis. Because if a patient has MS, multiple sclerosis, you have to treat them with the multiple sclerosis disease-modifying treatment. If you have a patient with NMO, all patients need chronic immunotherapy, with the classic medication being rituximab, and there's some other treatments for that. With MOG, if you have a single attack, we do not recommend chronic treatment because only 50% of patients are going to relapse. And if you do have a relapse, patients tend to do pretty well with relapse, especially with early steroids. And therefore, we actually reserve chronic immunotherapy for recurrent attacks. So again, different from MS and NMO, where you're really treating right away. For MOGAD, we kind of wait for the recurrent attacks before we start chronic immunotherapy. And in terms of the kind of chronic immunotherapy, it's actually, we only have retrospective studies to guide therapy, and they are different compared to MS and NMO. And these are just 5 of the most commonly cited, publications out there trying to guide therapy. But I thought I'd just go through just a couple concepts that all these studies have, all these studies share. Essentially, what all these studies look at are something called annualized relapse rate prior to starting the treatment, and the annualized relapse rate on treatment. What it means is how many attacks are they having per year? So if you had a patient who had 4 attacks over 2 years prior to treatment, then annualized relapse rate would be at 2 attacks per year. And obviously that's not ideal. If you have 2 attacks per year, you're going to get a lot of disability. And then let's say this patient was treated with a medication like rituximab and they had 1 attack over 2 years. The annualized relapse rate would be 0.5 attacks per year. So clearly better. Obviously, if the medication took you from 2 attacks per year to 1 attack every other year, we'd consider that an improvement. Not perfect, but improvement. And so all these studies, if you look at the abstract, they're all going to talk about the annualized relapse rate. This is what they're getting at. So I thought I'd just step through, our study that we published with a bunch of colleagues around the US and some around the world, where we looked at about 100 patients with relapsing MOGAD. And again, you're going to see pretty similar charts here, but I just wanted to highlight a couple of things. What you're going to see in these papers are these pre-treatment annualized relapse rate and the relapse rate on the treatment. And I know this is a little bit sciencey here, but it's an interesting concept because if you have this down, you can actually look at all these papers and compare the treatments. So again, we're going to be looking at analyzed relapse rate And an example is, 4 attacks over 2 years, that's 2 attacks per year. So I'm going to highlight what we found and what other studies have found. Again, our studies are very similar to what other groups have found too, are that MS disease modifying agents and treatments are not effective. What you can see is before they started the MS medication, they had about 2 attacks per year. And on the treatment, it was still close to 2 attacks per year. So really, these MS disease modifying treatments are not helpful for patients with MOGAD. Then if we look at the 3 very commonly used medications for NMO, they all seem to improve the relapse rate. So before the treatment, they're all at about 2 attacks per year. And then on treatment, they all reduced to about 0.5 attacks per year. So again, reduce the attacks by about 75%, but not 100%. So, these medications that we traditionally use for NMO seem to work for MOGAD, but they're not perfect. It was pretty striking. We found that we only had 10 patients, but these 10 patients that were treated with IVIG, you can see this pretty significant reduction in attacks where before treatment, they were getting about 3 attacks per year. And on treatment, on average, they weren't getting attacks at all. And so, this looked pretty promising, but of course, this is only 10 patients. But it suggests that maybe IVIG may be a good treatment for MOGAD, which is interesting because it's not a medication we typically use for MS or NMO. So we recently did a large international study where we had collaborators around the world contribute patients that were treated with IVIG. And we had 59 adult patients treated with IVIG from 9 countries and 14 centers. And ultimately, what we found is a pretty significant reduction in relapse rate. Again, before treatment, about 1.4 attacks per year, and the median annualized relapse rate was 0. But it wasn't perfect. There was still a patient that had 3 attacks per year. And overall, a third of patients still relapsed on IVIG. So again, it seemed pretty promising, and it still seems promising, but it's not a perfect treatment. We further stratified it based on the amount of IVIG. And so this is just over time, the chance of relapse on a low dose of IVIG, which is in blue. You can see that up to 40% of patients relapsed on the low dose. But on the higher dose, you can see here that only up to less than 20% of patients relapsed. So with the higher dose, it may be more effective in preventing relapses in MOGAD. The fact that there's this dose response, again, higher dose works better than low dose, also suggests that IVIG truly is helpful. Just depends on every patient might need a different amount of medication, a different amount of IVIG. And there's a suggestion that subcutaneous IG works as well. But based on all this data, it kind of shapes how we approach our patients with MOGAD. So as I mentioned before, they've got a single attack with pretty good recovery. We don't recommend chronic treatment. If they've got relapsing disease, that's when we start immunotherapy. And we typically start with rituximab or azathioprine. Again, very common medications that we used to use for NMO. And then if the patient breaks through rituximab, breaks through azathioprine, then we'll switch them over to the IVIG. And another medication that may work is tocilizumab. But again, these are the more traditional medications. This one only requires treatment every 6 months. This one's an oral pill. Again, they've just been used more, so we typically start with that, whereas IVIG needs treatment every month, tocilizumab as well. So that's how we approach our patients. And then if they're a pediatric patient, we usually use monthly IVIG if they've got relapsing disease, just because it doesn't suppress the immune system. It's pretty safe. So let's go back to our first case, and then I'm just going to step through an algorithm in terms of how, using that algorithm we just talked about, how we approach that patient. So again, this patient presented with very severe optic neuritis, could only count fingers. We knew it was optic neuritis, and taking him through the algorithm, we're going to treat him with steroids. And fortunately, they had full recovery. So at that point, we were pretty happy. So again, that patient had full recovery with the steroids. We were very happy. So we recommend 1 attack. We recommend observation, not chronic immunotherapy. Of course, with this patient, we observed, and unfortunately, they had a recurrent attack. So again, with the acute attack, we're going to treat them with steroids. And fortunately, he had full recovery, back to 20/20 in both eyes. But again, at this point, we're getting a little bit worried because now they've had 2 attacks. If they have 2 attacks, well, maybe now they're going to have 3 or 4 attacks, and maybe one of these are going to leave them with some permanent blindness. So it got us a little bit more concerned. At this point, you really have two options. If you got 2 attacks and complete recovery, you could consider chronic immunotherapy. And we talked about the medications, rituximab, ceftriaxone, mycophenolate, IVIG, and tocilizumab. Or you could still observe. Again, they've had 2 attacks. You're getting a little bit more worried, but gosh, they've got full recovery. So if we do opt to observe after 2 attacks, again, the patient has full recovery. If they have a recurrent attack, we're going to treat them, of course. But at that point, now they've had 3 attacks. And I'm not very happy about 3 attacks. That's just a ticking time bomb that is probably going to cause some permanent disability. So if they have 3 attacks, even with full recovery, we usually recommend chronic immunotherapy. If they have 2 attacks of full recovery, it's a little bit of gray zone. 3 attacks, we're going to be recommending chronic immunotherapy. So that's one scenario. And then again, this patient had 3 attacks. We put them on azathioprine, and the patient's done very well. It's been about 3 years and they haven't had another relapse. They're still 20/20 and perfect vision. So I've been pretty happy about this patient, and the patient's been pretty happy as well. So that's one scenario. So another scenario is you treat an acute attack and you treat them with IV steroids, but they don't recover very well. So if they don't recover very well, and 1 to 2 weeks in, that's when we usually add on plasma exchange, where we talked about how you essentially put a central line in, you take out their plasma, you take out the pathologic antibodies, and then we feed back the plasma without the antibodies. If they've got the 1 attack with full recovery, I'm happy. Even if you had to use plasma exchange, as long as they got back to full recovery, I'm happy. I'm going to recommend observation. Again, if they've got 2 attacks of full recovery, that's where you've got that dilemma. Do you observe? Do you do chronic immunotherapy? Another one that kind of gives us some pause is you've got 1 attack now, but incomplete recovery. Again, only 50% of patients are going to relapse. But if that 1 attack left you legally blind in 1 eye, you can't afford that second relapse necessarily. So sometimes the decision to treat here depends on how much of a deficit there was, how much of a delay there was in getting those steroids. So let's say, the patient did end up, 2200 legally blind, but it took, 2 weeks before the patient was recognized to have neuritis, recognized to get the treatment with steroids. You could think, well, the next time around we'd be much quicker and we could probably end up with a better outcome. So that all plays in. So these, in my mind, are a little bit of a gray zone. 2 attacks full recovery, 1 attack incomplete recovery. Sometimes we'll observe, sometimes we'll start chronic immunotherapy. And a lot of this kind of depends on the discussion with the patient, but this is that gray zone. Another thing that we'll actually add in is, do the MOG titers matter? And what we found, and a lot of groups have found, is that 75% of MOG patients will just remain positive. Just because they're positive doesn't mean they're going to relapse, but it does suggest, maybe there's a 50% chance of relapse. But 25% become negative. And if you become negative, there's only a 10% chance you can relapse. And then, so sometimes we'll check the MOG titers again 3 to 6 months in. If they become negative, that makes it less likely they're going to relapse, and that might shift our decision to treat chronically or not. If they're positive, there's a little bit of an increased risk of relapse. So we can factor that in here. Of a patient with 2 attacks in full recovery, or 1 attack in incomplete recovery, but now the follow-up MOG antibody is negative, it might lean us toward observation. So again, that's how we factor that into the decision-making as well. So again, this is that gray zone in terms of what to do next with chronic immunotherapy. And then, if there's persistent MOG positivity, that's where you're going to have that gray zone. Do you treat them or do you observe? And then the last, there's less of a gray zone here, is if you've had over 3 attacks or you're steroid dependent, you need chronic immunotherapy. Or if you have recurrent attacks and you've had incomplete recovery, you're going to need chronic immunotherapy. In my mind, this is less of a gray zone. That's where we really recommend that chronic immunotherapy. So again, you can see that it's a little bit more complex when you have a patient with MOGAD. We have a lot more longer discussions with our MOGAD patients than our NMO or MS patients. With MS, there's no discussion, you've got to treat. With an MS disease modifying agent. With NMO, no discussion, you've got to treat with rituximab or some of these other new FDA medications. As you can see with MOGAD, there's certainly some more wiggle room where sometimes we'll observe, sometimes we won't. And then, but again, if you've got a lot of attacks or attacks with incomplete recovery, we do treat. Something to look out for is we have upcoming randomized clinical trials for MOGAD. One medication is satralizumab, which is an IL-6 inhibitor. And this was proven to be successful in a randomized clinical trial for NMO. And we think that it's going to be successful for MOGAD as well. We're not currently recruiting for this yet, but this is right around the corner. And then there's a randomized clinical trial for rozanolixizumab. And essentially, this is the medication that essentially gets rid of pathologic antibodies. So the idea is it'll get rid of the pathologic MOG antibodies. It's been proven to be effective in other autoimmune conditions like myasthenia gravis. And this is going to be now applied to MOGAD. And I know there's already some centers in the US that are enrolling for this clinical trial. So if you have MOGAD and you've got relapsing disease, definitely ask your doctor about these potential randomized clinical trials, because this could potentially be a very good treatment for it and allow us to understand this disease better. So this is pretty exciting that this is essentially ongoing right now, and the satralizumab trial is just right around the corner. So I hope, from this brief talk, you could appreciate that MOGAD is associated with recurrent optic neuritis. They tend to have optic nerve swelling, a lot of inflammation on the MRI. And that's, a tip off for us physicians to say, yeah, this may be MOGAD. And of course, we confirm it with the blood marker MOG antibodies. With optic neuritis, they have severe vision loss at onset, but they have much better recovery. So the outcomes are much better than NMO. In terms of acute attacks, it's going to be IV steroids followed by that oral steroid taper over 1 to 3 months. And the chronic immunotherapy that we talked about is really for relapsing disease or patients that have significant attacks with incomplete recovery. And then perhaps IVIG and tocilizumab may be currently the best treatments for MOGAD if they have relapsing disease. A little bit different than NMO, where the best treatment is rituximab. So again, this is our current understanding of disease, the current way we approach these patients. And again, look out for these upcoming randomized clinical trials for MOGAD. It's really an exciting period of time as we have a better understanding and better treatment for this condition. And I'd love to open up for any questions the audience may have.
Wow. Well, first of all, thank you for such a comprehensive, easy to digest presentation. I definitely learned a lot. And clearly, as just from attendance alone, I can tell that I knew that this was going to be a popular topic. So thank you for that. And of course, thank you for the research and the work that you're doing to advance the knowledge of MOGAD. That's really important. So let's get to the questions. We have a lot of them. I'm going to start with one that I received via email. So what can Dr. Chen tell in general about the possibilities for recovery after reaching remission, even after several relapses?
Yeah, no, that's an excellent question. And so essentially, with the acute attack, we're going to be treating them with IV steroids, that oral prednisone taper. They don't respond within 1 to 2 weeks. We end on the plasma exchange just to try to get as much back as possible. And then that recovery, the bulk happens in the first few weeks, and then there's further recovery for 6 to 12 months. Unfortunately, once you kind of get to at 1 year, 6 to 12 months after that attack, that's where you're going to be. And fortunately for most MOG patients, that's pretty darn good. Patients tend to get very good recovery. But once you kind of get to that point, there are no good treatments to kind of squeeze out more recovery. It's just what the body's going to do. So again, I wish there was ways to kind of regenerate the nervous system, but right now we don't have good treatments. But fortunately, attacks tend to be very steroid responsive. Fortunately, patients tend to do pretty well, much better than NMO.
Wow, cool. All right. 21-year-old MOG plus daughter on rituximab is getting monthly blood work to see when B cells repopulate so that next infusion timing can hopefully be pushed out beyond 6 months. Should she wait for B cells to return before getting a bivalent COVID vaccine? Prior vaccinations did not produce B cells per spike AB test. If so, how soon after vaccination should she wait before the next rituximab infusion?
Gosh, those are good questions. So Usually the typical rituximab treatment regimen is every 6 months. That's how we do it at the Mayo Clinic. And it's interesting, we actually don't routinely check B cells at Mayo. We just kind of dose it every 6 months. If they've got a relapse, then we check the B cells to see maybe they're an early B cell depleter, because essentially we want them to be zero, and that's showing that the medication is working. So we actually don't typically check, but I could see if you want to extend out the treatment, that's something you could do. Wait for the cells to go up. Obviously, if the cells go up, then you're a little bit at risk of that relapse at that time. So that's why we tend to just go every 6 months. But I could definitely see you don't want so many treatments. Following the B cells is perfectly fine. Now, timing the vaccine, that's a tough one. Because obviously when your B cells are down, you're not going to mount a very good response to the vaccine. I don't think I would necessarily have to wait for the B cells to be back up, because again, that's when you're at risk of relapse. But maybe I would recommend the vaccine maybe 4 or 5 months after your last rituximab dose. And that might be a good compromise to try and get a response to the vaccine, but still leave you safe from relapses.
All right. Flu shots still recommended for MOGAD patients? If so, is it okay for it to be taken at the same time as bivalent COVID vaccination, or should MOGAD patients separate the timing? I understand it's okay to take at some same time for non-MOGAD individuals.
Yeah. So again, all these vaccines, it's always theoretically possible. They're stimulating the immune system to prevent the flu, to prevent COVID. And there's always the theoretical risk that it could stimulate the immune system and stimulate a MOG attack. Overall, we haven't really seen a huge spike in MOG with vaccines, but there's always case reports here and there if you look it up. You're always going to have case reports, and whether it's true and true related or just happen to be, because everyone's getting vaccines, it's hard to know. We are still recommending COVID vaccines. We are still recommending flu vaccines. Obviously, if you have MOG, you've got that small potential increased risk. So maybe I probably would separate the flu and the COVID vaccine by amount just to be on the safe side, but not great medical reasoning behind it. But if it was, my child or my sibling, I'd probably separate it by amount a month just to not rev up the immune system too much.
Okay. Why is azathioprine a first-line treatment given the cancer risk? I would have thought IVIG would be preferred.
That's a good question. So, with any of these immunosuppressions, there's always that small risk of cancer and infections. You're suppressing the immune system. Your immune system's job is to take care of infections, to take care of, cancers. Azathioprine, mycophenolate, rituximab, these are just traditional medications we used for NMO for many, many years. Obviously, there is that small risk, but they're still relatively safe. In terms of why we don't start right with IVIG, it's much more costly. It's every month. It's sometimes hard for insurance to get approval. There's a lot of barriers to getting IVIG to get approved at times. Sometimes insurance companies want to see a failure on another medication before they approve the IVIG. And of course, paying for IVIG out of pocket is very, very costly. With some of our recent studies suggesting it is very, very effective, we've actually been shifting a lot more to sometimes actually just starting off with IVIG. So I think it's a very good point. Again, traditionally, we started with rituximab or azathioprine and then switched over, but we have been starting IVIG much more sooner, often as first-line therapy now. So that could be an adjustment. Again, with these publications, it's helped combat the insurance companies. So again, the tradition has been azathioprine or rituximab, but you're right, we may be shifting much more to IVIG, even as first-line.
All right, here's a long one. It's a little bit of a tough one. Hi, Dr. Chen. My 3-year-old daughter suffered optic neuritis, ADEM, and transverse myelitis as a result of MOG antibodies at 15 months old. Oh, bless her heart. She went completely blind and stayed that way for about a month. She regained vision over about 8 months. We are 2 years out from the attack now, and she has regained functional but not perfect vision, 20/80 in the right eye and 2100 in the left eye. The doctor says her nerves are pale. Her brain has healed a lot too. She has just tested negative for the first time Initially 1 in 1,000, 1 to 32 a year later, and now negative. That's great. My question is, do you think it's too risky to cease treatment? She's been stable on monthly IVIG. As parents, we fear what a second attack could mean for her vision, especially if we miss an attack due to her young age. Oh,
Wow.
so, yeah, that's tough.
That is a really, really tough one. I think I'm glad that she's negative now. That means that the chance of relapse is probably lower on that 10%. But that's still a potential 10% risk in a patient who, I think you mentioned the vision was 20/80, 20/100. So not legally blind, but still, pretty visual, a good amount of vision loss. And obviously we can't really afford that another relapse. She's only 3 now, if I recall. And therefore, I can't really tell reliably, that there's eye pain and there's vision loss. So in my mind, I would probably recommend continuing the IVIG as long as she's tolerating it well, at least until she's 5 or 6. And if she consistently tests MOG negative, and then at 5 or 6, she can tell you when there's eye pain and vision loss consistently, then you could consider kind of tapering off. But I think probably for at least the next 2-3 years, I would recommend the IVIG to try and keep her safe. Even if there's only a 10% chance of relapse, she may, at the age of 3, she may not be able to verbalize that relapse. And again, we think early steroids helps. But in a 3-year-old, you might not be able to capture that early steroids. So at least until they're able to kind of tell you their symptoms a little bit better, I think I'd err on the safe side, especially if they're tolerating it, especially because we know IVIG, if they're tolerating it well, doesn't have long-term risks of, cancer and infections and things like that. So that would be my recommendation, at least until she's old enough to talk about her symptoms a little bit better. And then when that happens, maybe a slow taper off, instead of every month, then go every 5 weeks, every 6 weeks, and just see how she does.
That's great advice. Nothing upsets me more than sick babies and children. Not fair. All right. I presented at age 39 with ADEM. I am also being told I have MS. What is the likelihood for those with MOGAD to also have MS? That's a great question.
That is a good question. We think they are distinct entities. If you had ADEM, I think you probably have MOG. ADEM is pretty rare for MS, but it's very common for MOG. So the fact that you had ADEM, I think you probably have MOG. You probably have a few scattered white matter changes that might make them think MS. But again, I think I would treat this as MOG. If you've had recurrent attacks, and again, they're contemplating MS, you definitely want to be on a medication that would potentially treat both of them, like rituximab or ocrelizumab. I wouldn't swing toward an MS medication that's specific for MS because it wouldn't work for MOG. And the fact that you had ADEM makes me think you probably have MOG. And we really think they're different diseases with different pathogenesis and different treatments. But again, if there's that question, just use a medication that's going to treat both.
Okay. I've read that MOG antibodies wax and wane and sometimes are never found again after the first attack. How do you handle patients who never test positive for the MOG antibody? Is there a clinical MOG diagnosis for them, or do you consider them as seronegative NMOSD patients?
That's a really, really good question. So we can know the specificity of MOG, but we don't know the sensitivity yet. So if a patient has a MOG phenotype, but it looks like MOG, but they're negative for MOG antibodies, they're negative for NMO, aquaporin-4 antibodies. One more additional thing that you could consider is actually getting a spinal tap, getting the cerebrospinal fluid. Again, the serum antibody is still the best assay. It's the most sensitive, it's the most specific, but there's about 2% of patients that could be missed where the antibodies are just in the CSF. So again, we never start that really. That's something that we've kind of shifted over. If someone has a really strong MOG phenotype, it looks like MOG, but the blood is negative, we'll get that spinal tap and look for the antibodies in the CSF. And then could you have seronegative MOGAD? It's very controversial whether that exists or not. It's very possible that our antibody is just not sensitive enough, or it's possible there's some other antibody that we just don't know yet. that's causing a mimic. But either way, I would probably throw you in that seronegative NMO category and treat you with a medication like rituximab or something that kind of treats multiple diseases if you have relapses.
Great questions. Very
Those
thoughtful.
are very good questions.
Do you feel like you're on a show, like a game show?
It's perfect. I mean, they're hitting right at the cutting edge. You know, the CSF MOG is just right at the cutting edge of understanding. You know, these are some really excellent questions.
If there's anything I've learned in my 8 years of advocacy in this community, it's that the patients are very, very smart. They get smart on this and they're curious. So these are great. I love it. Okay, next question. How quickly should the treatment with IV prednisone start one day? And is it better with IV prednisone or is oral okay?
Oh, that's a good question. So in terms of how fast, I would say, you know, your first attack before you're diagnosed, you're never going to have super fast treatment because no one knows that it's going to be an optic neuritis. This is your very first attack. Usually, you know, there's a 2, 3, 4 day delay before the diagnosis, the treatment. But if you carry a diagnosis of MOGAD, you know what your symptoms of optic neuritis are, pain with eye movements, decreased vision. You can get treatment very early if you were to relapse. And, you know, usually in patients who carry a diagnosis of MOGAD, we try to get the treatment within, 12 to 24 hours. Sometimes we even prescribe high doses of oral prednisone that they keep like in their pocket, and essentially steroids in the pocket. And if it happens at Friday at 10 o'clock at night and they can't get to anyone, but they know it's an attack, they can just take the pills there and then. So that's something we've been doing clinically. In terms of the questions of IV steroids versus oral steroids, the route probably doesn't matter, but the amount does. And so with IV, we give 1,000 milligrams, which is super high. And then the equivalent by mouth is 1,250 milligrams. So that's 25 50 milligram tablets, because the 50 milligram tablets are the largest they come in. But you need to have that amount to kind of treat these acute attacks. The lower dose of, what we think is a high dose of like 80 milligrams isn't enough. You really want these big whopping doses. So the route doesn't matter. You can do oral, but you need to do a lot for those acute attacks.
Nice transition to preventative therapies. What dose of IVIG and rituximab would you give? And how long would you wait before you start plasma exchange?
So the plasma exchange, again, goes back toward acute treatment. Again, usually patients respond to IV steroids. So we're not doing plasma exchange that much, but if they've got a bad attack and we treat them with steroids and it's been a week and there's nothing, we're going to add plasma exchange on top. Again, that's very different than NMO where they're getting treatment with plasma exchange right away. In terms of chronic treatment, again, now you've got relapsing disease. That's where the IVIG and the rituximab comes in. With rituximab, we do 2 treatments every 6 months to make sure that the B cells stay depleted. And then with IVIG, it's a little bit more variable, but the dosing is by weight. And we think a good starting dose is 1 gram per kilogram every 4 weeks. And in the paper that just got published in JAMA Neurology, we found that patients treated at a pretty standard low dose of 0.4 grams per kilogram had higher relapses than those at the higher doses of 1 gram. And then we actually had no one who relapsed out of 10 patients who had 2 grams per kilogram, but that's a pretty whopping dose. So we usually start with 1 gram per kilogram every 4 weeks. If they have a relapse, then we kind of go to the bigger whopping dose of 2 grams. And we're no longer offering that low dose of 0.4 grams per kilogram every 4 weeks.
Dr. Chen, what is your view on the use of, I'm going to butcher this, clemastine as remyelinating therapy after multiple MOGAD relapses? This is referencing the Rebuild study, Green et al. In Lancet 2017.
That's a very good question. So the clemastine is, again, the holy grail. Right now we're talking about of acute attacks, treatments to prevent relapses, but the holy grail is to regenerate the optic nerve, regain function in a damaged nerve. And so clemastine was trying to get at that. It's a medication that is thought to maybe improve, remyelinate the nerve to allow better conduction. Essentially, it was a randomized clinical trial published in 2017 looking at optic neuritis, and there was some mild improvement in the visual evoked potential, which is kind of looking at the speed of the passage from the eye to the brain. It was pretty mild. There wasn't an improvement in things that we can detect more, like visual acuity or visual field. So it was pretty marginal. So it's not something that we routinely use for our patients. It has pretty minimal side effects. So if you wanted to try it, it'd be perfectly fine, but it's not something we routinely do just because, yes, maybe we can get a lab test, a visual evoked potential test a little bit better, but functionally, in terms of being able to see the letters on a chart or pick out details, it didn't seem to help. That's not something we routinely do. And we're still looking for that next drug, that next medication that could truly improve optic nerve function.
Okay. Is there any trial or surgery testing for optic nerve transplant or replacement? I am an NMO patient and have lost 100% of my sight in the left eye.
That's a good question. In the future, it's going to be stem cells. If it's vision loss in one eye, it'll be stem cells. So right now, we can actually take a skin biopsy, and grow an optic nerve in a dish. But we don't know how to make that optic nerve grow from the eyeball to the brain. It has to go all the way to the lateral genetic nucleus, which is in the middle of the brain. We don't know how to make that nerve grow back there yet. And so we've got some time before, first we have to make it work in an animal, then we have to make it work in a human. But we have it working in a dish. So I think it's just a matter of time before we get to do that. But we don't have that technology yet. If you look hard enough, you'll find stem cell clinics that aren't necessarily in the country. But I wouldn't recommend that because there's just no science behind it. They're just taking stem cells and optic nerves that you can grow and injecting into the eye, but there's no science that's working. And there's been some reports of patients who actually had a somewhat seeing eye and went blind from it, from the inflammation that can occur. So I wouldn't recommend stem cells yet, but it's the future. And another thing in the future, if you were to have bilateral optic neuritis and bilateral blindness, something in the future would be cortical implants where they can actually put microchips into the back of the brain. And there's some studies going on where you can actually see, a little bit of movement right now, and hopefully that'll improve over time.
What is your position on MOGAD patients who are steroid dependent? Are there any studies to differentiate between oral and IV steroids? Oral or IV steroids and the different drug delivery systems and long-term side effects? Follow-up question to that is, what is considered a high dose of IVIG, obviously dependent on body weight?
Yes. So again, if you're steroid dependent, again, usually with the acute attacks, it's high dose, either IV steroids or high dose oral prednisone, oral steroids. Either one is fine, but you're looking at that 1,000 milligram kind of dose. And then you kind of taper off, and we hope we can get you down to 10 milligrams or less, and you don't have relapses. If we can do that, you can actually be on 10 milligrams of prednisone the rest of your life because your body generates about 10 milligrams of prednisone. So that's not going to cause any long-term side effects. But if you keep relapsing at 30 milligrams or 20 milligrams or 40 milligrams, that high dose steroids is not sustainable. Then you're going to get weight gain, diabetes, thinning of the bone. That's when we look for other treatments like IVIG. And then, as you mentioned, what's considered a good dose, that it's going to be that dose by weight. 1 gram per kilogram is our starting every 4 weeks. And if you keep relapsing through that, 2 grams per kilogram every 4 weeks, or a low dose, 0.4 grams per kilogram every week. Just kind of different treatment regimens.
Why not start with plasma instead of steroids initially, since the taper off of steroids can be so rough with side effects?
Why not start with plasma exchange? Is the question?
Yeah.
Yeah. So the plasma exchange, again, is there to try and improve that acute attack. It's not going to be a chronic treatment. That oral prednisone taper is there to prevent relapses. The plasma exchange is there to try and get that recovery. The reason why we start with steroids first is because a plasma exchange usually requires a central line and has potentially more side effects than the steroids. But that's a good question. because plasma exchange may be, more effective for some of these antibody driven diseases like NMO and MOG. So obviously it's something we're looking more into. But the drawback is it's a costly, potentially, dangerous treatment, where you have that central line and you've got to be in there circling out that blood for 2-3 hours. It's not quick or easy.
MOGAD prevalence may be higher than NMOSD, as much as 3 to 4 times higher, but may be significantly underdiagnosed. What is the best guess estimate of MOGAD prevalence in the United States?
Yeah, I think that's an excellent question. I do agree that it's about at least twofold more common than NMO, especially as it relates to Caucasians. In Asians and Blacks, NMO is actually more common probably than MOGAD. MOGAD just seems to be pretty common, just equal throughout all races. But in Caucasians, I agree, it's more common than NMO. We actually did an incident study in Olmsted County looking at our patients with optic neuritis, and we went and drew every single patient who drew their blood in Olmsted County who had an optic neuritis attack from year like 2000 to 2016, and we kind of determined the incidence of MOG optic neuritis, and it's kind of in that, I don't remember the exact numbers, but it ended up being at least twofold more common than NMO.
Straightforward one. What kind of blood work should a MOGAD patient have regularly? I do not have any, and I'm currently on rituximab.
Yeah, so for a MOGAD patient, again, we usually tend to check the titers, maybe 6 months in and then a year out, just to see, are you a transient positive or are you persistently positive? Doesn't necessarily change what we decide, but if you become negative, maybe a lower chance of relapse. In terms of rituximab, we get treated every 6 months, and we don't routinely have to check that much for blood work with rituximab. The main one is if you have a relapse, we'll check your B cells to see if they're still 0 to make sure that rituximab is still working. Those are kind of the main surveillance that we do with rituximab. So really the surveillance kind of depends on your medication. Like azathioprine, you have to have your liver enzymes checks and other things like that.
For MOGAD patients who have had 1 or more recurrent attacks and then receive appropriate treatment, what is the typical long-term prognosis?
So as long as if they've had 1 or 2 attacks, that's kind of when you're in that kind of gray zone. Do you need to put them on chronic immunotherapy or not? Certainly, if you've got 1 or 2 attacks and you've got a lot of deficits in one eye or you've got weakness in one leg, we would be putting you on chronic treatment. And in terms of the long-term outcome, it really depends on preventing those future attacks. We now think that IVIG, tocilizumab, all these are pretty good medications in preventing relapse. So I think the long-term outcome is good. With multiple sclerosis, you get something called a progressive phase where patients just decline. Even with treatment, they just keep getting worse. With MOG, fortunately, that doesn't happen. Patients are stable unless they have a relapse. And if they relapse, we can treat early and get them back to their baseline. So overall, I would say outcomes and prognosis is good because we've got good treatments to prevent relapses. And then if you do have a relapse with early steroid treatment, patients tend to do well. So I think it's a good prognosis.
Okay, we have time for 3 more questions. So I'm going to pick 3. Dr. Chen, is there any experience with a combination of Plex and IVIG as treatment? I'm struggling to get off of prednisone. Every time I get below 20 milligrams, I have an attack. I've been there. I get it. It sucks.
Yeah. So it sounds like you're very steroid dependent. There, again, Plex we don't use for maintenance therapy. We don't do it, we don't Plex everyone every month. But if you can't go below 20 milligrams, it sounds like you're going to need a chronic treatment. And again, the options are, I think, IVIG would be perfectly fine for an initial start. And if you have a relapse and you're not responding to the steroid, that's when we add on the plasma exchange, maybe IVIG. But for you, it seems like you're doing okay, and then you get to 20 milligrams and you're having a relapse. You need some kind of chronic treatment. So could be rituximab, azathioprine, But I think jumping right to monthly IVIG would be perfectly reasonable. Tocilizumab would be another option. Or you could actually, you may be a great candidate for one of these randomized clinical trials. Again, essentially, I think they're looking for any patient who has a relapse within a year. So that could be an option too.
This is a good one. I like this one a lot. Okay. Do you recommend routine NMO and MOG antibody testing for all severe optic neuritis patients? And just to follow up to that, Dr. Chen, from my curiosity, how many more patients do you think you'd get out of that if you tested all optic neuritis patients?
Yeah, that's a good question. So bottom line is severe optic neuritis, yes. There's no doubt about it. If it's severe optic neuritis, it's going to be less likely to be your typical optic neuritis, and you're really thinking more MOG and NMO. So, and then if you're positive, it changes your prognosis, it changes your treatment. So any severe optic neuritis, I feel like you've got to test. Then the big question I guess asked is, she just check every optic neuritis? And I would say, unless they're classic MS. So what I mean by classic MS is the periventricular white matter lesions, positive glauconal bands. I mean, if it's MS, it's MS. But if it's not, if you don't have the periventricular white matter lesions on the MRI, I actually think you should, because these antibodies are pretty specific, especially the aquaporin 4 antibody, and it will definitely change prognosis, change treatment. So really, right now we're getting on pretty much every optic neuritis unless it's screaming optic multiple sclerosis. And then in terms of how common they are, again, everyone in my clinic has either NMO or MOG, so it seems like it's every patient. But again, we have something called the Rochester Epidemiology Project, where again, we could determine how common these diseases are in the general population. And so we took, again, everyone in Olmsted County, drew their blood. And in terms of optic neuritis, 50% were MS, 5% were MOG, and 3% were NMO. So it's
All
about
right.
that much.
Last question. For relapse rates and titers, are you referring to titers while not on therapy? For example, if the titer is a negative result while on rituximab, does that mean 10% relapse risk or not because it's due to therapy?
That's a very good question, and we don't entirely know right now. Again, the fact that you're on therapy probably does influence the MOG titers, but it's surprising it's not that responsive to the treatments. If you become, let's say you're on rituximab, now you've got a negative result, I would say that does mean there's less likely of a relapse. If you're doing very well over a couple of years, it's something you could consider trying to come off and then rechecking the MOG titers to see if they come back. If they do, then you're like, okay, well, maybe I do need to be on rituximab. So I would take that as a good sign, but not a definitive, because it could be just from the treatment.
Okay. This was a lot of fun and very informative. Thank you so much, Dr. Chen, for your time and for all of this wonderful information and for answering all these rapid fire questions. Super fun. And I'm excited to meet you in Boston next week.
Yeah, I'm excited as well. And I really enjoyed chatting with you all today. And again, amazing questions. And, if there's any questions we didn't get a chance to talk about, I'm sure you could reach out to us, and I'd be happy to chat, offline, or, send some emails as well.
Absolutely. If you submitted a question and it didn't get answered today, sorry. And also you can email the foundation, contact@sumairafoundation.org, and we'll get these questions answered for you. Thank you all. Have a wonderful day, evening, morning, wherever you are. And Dr. Chen, thank you.
Thank you so much.
Ciao.
Bye, everyone.